So today we're going to be talking about insomnia, how we use psychotherapy techniques to treat insomnia, and giving different case examples to highlight some of the complexities that we're going to see across different cases and across different patients. So I think it makes the most sense by starting by talking about what is CBT, what is cognitive behavioral therapy broadly, and then how do we apply that to treat insomnia and sleep disorders. So those of you who, you may have heard about CBT before. It's probably one of the most popular forms of psychotherapy that's done today because it's evidence-based. That means there's a lot of research supporting that these therapeutic techniques can work for a lot of people, as long as they're willing to put in the work and have openness to learning some of this stuff. Essentially, what we're doing in CBT is we're promoting change across 3 channels: thoughts, feelings, and behaviors. And in order to do that, we're helping clients become more aware of the ways in which their thoughts, feelings, and behaviors are all interconnected with one another. We want to help demonstrate to the patient the ways in which their thoughts and behavioral patterns might be maladaptive, right? It might be keeping them stuck. It might be preventing them from reaching their goals. And we want to help them change those things. We want to help them think about situations differently and engage in new behavioral patterns that bring them closer to the life that they want to live. I like to think of CBT as to increase flexibility and widen the person's range of possibilities, and to start getting them to think about things in a new way and try things they've never tried before. And this is going to help them generate more helpful thought and behavioral patterns moving forward. So here I have an example of how CBT can be applied to something that's not sleep related, because we can use CBT to treat a wide range of conditions. So for instance, here we have an example of a patient I worked with who had social anxiety. So they were really anxious about engaging in all kinds of social situations, but especially going out and meeting new people at parties. So they came in and they said to me, well, I have this party coming up on Saturday, but I'm really worried that when I go, people just aren't going to talk to me when I'm there. So understandably, as a result of that thought, they had feelings around it. They had a lot of anxiety. They were worried about embarrassment. There was a deep sense of shame that was activated from those thoughts. So there's a lot of different behavioral outcomes that we can see that can manifest in response to those thoughts. So they might say, you know what, I'm not going to attend the party. I'm too scared to go. So they avoid it altogether. Or they might go, but then they kind of keep to themselves while they're there. They don't make a whole lot of eye contact, or they sort of stay in the corner. They're not fully engaging and participating in the experience. Now they end up leaving feeling even more rejected than they did before. So we want to help the client become more aware of the ways in which their thoughts are influencing their behavior and help them change it. Maybe not completely, but to a thought that's just a bit more realistic, right? That holds both parts of what they might be feeling and thinking. So they can acknowledge the discomfort. I probably am going to feel uncomfortable while I'm there, but there's actually no evidence that people just won't talk to me. And in fact, I might make new friends, right? So now we're opening this range of possibilities. That generates different feelings. They might still feel a bit nervous, but now there's also the opportunity to experience some excitement around what could happen at the party. And this would provide them with the opportunity to engage in new behaviors. It's really helpful to develop goals and say, okay, when I go there, I'm going to work on talking to 3 new people at the party. Now they've engaged with new people. Perhaps they've had some positive interactions. Maybe they made some new friends while they were there. And as a result of that, that behavior is going to get reinforced, right? We're going to continue to encourage these more adaptive behavioral responses. So now that brings us to the next part of this discussion, which is how does this apply to CBTI? Well, what is CBTI? Next slide, please. Yes, thanks. It's cognitive behavioral therapy for insomnia. What's really neat about this, it's a short-term therapy. I mean, it works in a fairly quick amount of time. Typically, we're going to see it anywhere from 5 to 7 sessions. It could take a little bit longer depending on the complexities and comorbidities that the patient is presenting with, but overall, it's a fairly short-term treatment. It can be done weekly or bi-weekly is typically the cadence that we're going to be meeting with the patient with. And again, we're essentially modifying behavioral and cognitive strategies that are perpetuating insomnia. And I like to think of CBTI as having a few major goals. We want to replace the maladaptive strategies that are keeping the insomnia going. Previous slide, please. Go 2 back. One more. Thanks. So we want to replace those maladaptive strategies that are keeping the insomnia going. And oftentimes, these are strategies that patients aren't aware of. In fact, much of the time, it's behaviors that they're doing to address the insomnia unwittingly. And we're going to talk about this a little bit later on today. But part of what we're going to help the patient do is we're also going to help them understand the sleep processes, right? How can we really address the problem if we don't really understand sleep and how it works? And one of the main principles we're going to be talking with them about is sleep drive. How do we increase sleep pressure so that we can improve their sleep quality? And lastly, what we're going to do is we're going to be educating them around sleep hygiene behaviors. We want to help them understand healthy, adaptive techniques that are going to improve their sleep, not necessarily in one night, but in the long run, so they can enjoy durable results and benefits from the CBTI. So we always need to start off with some sort of assessment when the patient is coming in, right? I want to get a really good understanding of what is going on. And with that comes an intake. We want to know, when did the problem start? How long has this been going on for? What are some of your major concerns? Is it falling asleep? Is it staying asleep? Is it, gosh, I want to be waking up at 7 every day, but I wake up at 4 and then I can't get back to sleep, right? So early morning awakenings. All different kinds of variables that we're going to be looking at. What are some of the comorbid medical conditions that might be playing a role in all of this? Sleep apnea is a big one, right? If there's undiagnosed or untreated sleep apnea, that would be important for us to be talking about with the patient and make sure that they get lined up with the right resources to be evaluated for that. Where we would start is we would give them something called a STOP questionnaire. It's a brief 4-question questionnaire that just gives us a sense if the patient should be evaluated for sleep apnea. So a couple of the things that might be on there are, do you snore more loudly than most people? Do you get feedback that other people can hear you from another room snoring? Have you gotten feedback that you stopped breathing in your sleep by someone who's observed you while you were sleeping? So this can give us a sense if the patient might be presenting with some of these concerns. We also want to have a good sense of this person's circadian type, right? We all know folks in our lives who are morning larks. It's 4 or 5 a.m. in the morning and they wake up singing. I know I'm not one of those people. We all know a couple folks like that in our lives. Then we have the night owls, right? The people that can stay up and get their most productive work at night and just really get a lot done in those evening hours. However, the grand majority of us are going to be the intermediate type, the folks that just kind of fall somewhere in the middle. You're going to bed roughly between 10 to maybe as late as midnight. And you're waking up somewhere between 7 to 9. So we want to get a sense of where that person falls. There's a couple different ways we can figure that out. One strategy is when you were a kid and you were free to go to bed whenever you wanted and wake up whenever you felt like it. Summer vacation, right? You don't have school. What time frames did you generally fall into? Now, while there can be changes to people's circadian rhythm as they go through life, right, as we age, that can change, there's a certain tendency that we're going to see in people. So having that childhood sleep time can be helpful, but also we give a questionnaire where we ask them different questions about their feeling best rhythm. When do you notice you're feeling your best and brightest? If you had to take a serious exam, what time of day would you want to start it? If you had to wake up and start exercising at 7 a.m., how would that feel for you? So this gives us a sense of where that person might fall. Granted, we have to keep in mind that with work and different responsibilities, we may not be able to align perfectly with our circadian rhythm, right? But that gives us information, where we're able to provide the person saying, you're a night owl, but you work an early morning job, right? So we have to think about how that might play into your sleep and how you're going to feel. We also give a questionnaire about any beliefs or attitudes they might have about sleep. There might be, different sources of information that are influencing how they sleep. So a common one that we might hear is, I'm not getting my 8 hours of sleep. I'm really worried about how that might be affecting my long-term health. I'm only getting 7. Okay, well, you might be a 7-hour a night sleeper. I mean, that golden 8-hour rule doesn't apply for everyone. So we want to get a sense of how their beliefs might be influencing their sleep-based perceptions. And then there's a couple of different tracking measures that we're going to use over the course of the therapy that are incredibly useful. One is an insomnia severity index. And we administer over the course of therapy. So each time they're coming in, we're giving this to them. But what's really neat is we're able to get objective, quantified data around how significant they perceived their insomnia to be when they started and where it was when they ended. And I think that's one of the just most useful numbers that we can get, because we can see really fantastic improvements around this number. Ideally, we want to see that going lower, right? We want to see their insomnia getting less severe and that they feel that their functioning is improved as a result of their sleep improving. Another really useful tool that we're going to use is sleep need questionnaire. Again, very simple, 4 questions, and we're going to use this to determine how much sleep we're going to be allotting them over the course of treatment. Okay, so when the patient's first starting out with us, it's very psychoeducation heavy. And I would say it stays that way throughout the treatment, but it really is, we're front loading a lot of education to them in the beginning to help them understand sleep and how it's influencing them. So we start off with this diagram. And we really apply it to the patient because there's 3 different factors that we're going to see that all play a role in insomnia. So first, you're going to see in the orange, there are predispositions, right? We all can be predisposed to certain things. And insomnia could be something that we're predisposed to. So one of the things we want to find out about is, do you have family members with insomnia, right? The same way that we might see certain medical conditions that we could have a predisposition to, insomnia works the same way. Also, are there any childhood or life factors that might be influencing your struggles with sleep today? If you grew up in a chaotic or very unstable home, that might make you a little bit more on edge. And as a result, you're more predisposed to developing insomnia later on in life. But notice that with anything else, just because we have a predisposition doesn't mean we're going to develop the condition. There needs to be some sort of precipitant that's going to set the insomnia in motion. And that's where we see the blue spike and raise that person past that threshold. Typically some sort of stressor in life. So it could be with the veterans, they were deployed and when they came back, they had sleep issues. Lack of housing, going through a difficult divorce. These are all things that can create enough stress and anxiety where sleep now starts to become problematic for the person. Then we get to the perpetuating factors. These are the ones that are the bread and butter of CBTI. What are the behaviors that are happening today that are affecting your sleep, right? We can't really do a whole lot if there's a predisposition. The precipitant already happened. But what's happening in the here and now that's keeping the insomnia going? And as mentioned previously, oftentimes these are factors that the patient is unwittingly engaging in to improve their sleep. That's keeping the insomnia around longer. A big one we're going to see is excessive time in bed. Gee, if I can't sleep and I extend my sleep window bigger, Maybe I'll catch more sleep. It makes sense in theory, but it's actually one of the things that creates a lot of disrupted sleep and poorer sleep quality. So this is one of the key principles we're going to work with patients on. Another big thing is worry. We're so busy as we move through our day that when we first get into bed, that's the time that our brain likes to unpack things from our day, from our life, from all the things that we have going on this week that we need to do. So this is another one of the things we're going to work with patients on, is really avoiding spending a lot of time worrying, planning, ruminating while they're in the bed. So now that brings us to the different processes that are involved in sleep. Another important thing for us to be educating patients around. So the first process is that we're going to touch on is sleep drive. And the easiest way to think about sleep drive is that it's a biological drive within us, just like hunger is. So when we're hungry and we eat a snack, what's going to happen to our hunger drive? It's going to reduce, right? We're going to decrease that drive. Sleep works in a very similar fashion. If we sleep, if we take a nap, that's going to lower the sleep drive. Now, what you're going to see on the model here is just a theoretical model for thinking about how sleep drive tends to work. When we first wake up in the morning, our sleep drive is going to tend to be lower. It may not feel that way, but it is, because we've just gotten however many hours of sleep. And as we move through our day, that sleep drive is going to change. I bet many of us can relate to feeling a bit tired and sluggish a little bit after lunch. This is because our body temperature dips, usually anywhere from 7 to 9 hours after we've woken up. So that's where the sleep drive gets a little bit lower. But overall, what we're going to see is as we get into the evening hours, our melatonin production is increasing and our sleep drive is going to go up. Another factor that we want to be thinking about in terms of the sleep processes is the circadian clock, right? It's that little 24-hour clock in our brain where we're functioning on this 24-hour cycle. The last sleep process that we want to be also considering are alerting signals. Now, our alerting signals are the things that keep us awake, right? If we didn't have alerting signals, every time we increase a little bit of our sleep drive, we'd fall right asleep. So the alerting signals keep us awake, keep us functioning through the day, even when that sleep drive starts to increase a bit at different times throughout the day. Now, the variable that we're going to be manipulating in this therapy is the sleep drive. We want to create more sleep pressure. And that's what the patient is presenting. They're essentially telling us in one way or another, my sleep pressure is not working, my sleep drive's not high enough. So that's what we're going to help them work on. So now here's where we really get to the key sleep interventions. Now, we're going to start off by having the patient do some sleep tracking. And this is going to be very, very important throughout therapy, is we want to really get a sense of what's going on with their sleep. And they're going to do this in a couple different ways. So some folks tend to feel comfortable with just more of a paper log that we provide, but a lot of folks will feel more comfortable using an app. So it's a free app that I use called CBTI Coach, where they are able to do something called a sleep diary that they fill out each day. It's a very simple tool. It's going to ask just several questions about their sleep based on the previous night's sleep. So what time did you get into bed? What time did you wake up? Did you take any naps the day before? And we're going to be able to take all of this data and crunch it into a master sleep calculator. We're also going to ask them a little bit of subjective data. So let's say, for instance, the client is working on titrating off of their Ambien. They would make notes of this in a little journal entry. We want to know anything different or unusual about their sleep so that we can also be getting that information as well. Perhaps they had a cold for a few nights and that affected their sleep. So we want to just also get a picture around what's going on qualitatively as well. Once we get this initial sleep data, we're going to create something called a sleep window for them. So let's say the patient's coming in and they're getting about 6 hours of sleep a night in a typical week or two, but they're in bed for 8 hours. It's really useful to point out this discrepancy for them. You're sleeping 6, but you're in bed for 8. Now your sleep efficiency is not very good. What is sleep efficiency? What percentage of the time you're in bed are you sleeping? The more time you're in bed awake, the lower that percentage is going to be. We want to get the patient into the 85 to 95% range. 85 to 95% of the time that you're in bed, you're sleeping. So that's the goal. Now, once we develop this sleep window with them, let's say it's the 6-hour window, we're going to work with them for a couple different factors. Well, what time do you want to or need to be waking up? Let's say it's 7. Then we would backpedal 6 hours. So they say, I gotta go to sleep at 1 a.m. That sounds terrifying. I've been going to sleep at 10. I don't wanna do that. I'm gonna get even more sleep than I would before. Right? We normalize this. Really, you're not going to be getting that much less sleep. I mean, you will be getting a little bit less because now we've made your window smaller, but we always match it to the amount of time that you're sleeping unless it's less than 5 hours. We never give the patient less than 5 hours. With the veterans, a lot of them were sleeping less than 5 hours, but it's just not safe to give less than that amount. But that normalizes it. You're going to be getting the window that matches what you're already sleeping. That's because we need to make your window smaller first, and then we expand it out. Quality, then quantity. So what you're going to see on this graph there is, we show them, this is what your sleep can look like. We see the S's, but we see these wakenings sprinkled throughout your night of sleep so that it's disrupted. By reducing your time in bed, we're going to increase your sleep efficiency. And then as we go over the course of treatment, we're going to titrate it up by 15 to 30-minute intervals. So it's kind of like a reward. Once your sleep becomes more efficient, then we can give you more time in bed. So we like to call this sleep efficiency training. I mean, for those folks in the CBTI world, we call this sleep restriction therapy, but that can feel a little scary for folks. I mean, for folks who are already struggling with sleep, the idea of restricting their sleep can sound threatening. So we say we want to make your sleep more efficient. Now, another principle that's super, super important is called stimulus control. When you're unable to sleep, what are you doing in that time? Most folks are going to tell you, well, I sit there and I toss and turn and I pray that I'm going to be able to get back to sleep. And we say, okay, well, how does that make you feel? Anxious, frustrated, aggravated? Sure. So what if we move away from sleep effort and get you out of the bed doing something else? Reading a book, listening to some relaxing music, doing something that allows you to get out of the bed, and then having your body dictate when you're getting back to bed, rather than trying to force a sleep process, rather than trying to force a process that doesn't want to be forced. So we're really going to encourage them to only use the bed for sleeping and sex and to refrain from other activities. A lot of folks have been spending a lot of time in bed, perhaps working on their laptops, right? All of this encourages the brain that I use the bed to do other things. So we want to, in addition to restricting their time in bed, we also want to start training their brain that the bed is just for sleep. So a few other key sleep interventions that we want to be talking with them about are avoiding naps. We come back to the sleep drive. What is a nap going to do to your sleep drive? It's going to lower it. The one exception we would make is for safety naps. If you're going to be driving a vehicle and you feel that you're sleepy enough that there's a risk involved, then certainly we would want you to sleep. But aside from that, we're really going to discourage sleeping in order to increase that sleep pressure. Also very important is a buffer zone. What are you doing before you get to sleep? Oh man, well, I work late. I work till 10 p.m. and then I try to get into bed by 11. Really? Well, what time are you giving your brain and body to really relax, to really decompress from all that you've been doing that day? You're not giving yourself enough of a transition. And it's really helpful to think about sleep as a 24-hour process. Sleep's not just something that happens when we get into the bed and we expect it to just occur, but what are the things that we're doing throughout the day that could contribute to healthy sleep at night? So one of them is going to be a buffer zone. Another is going to be avoiding worrying or planning in bed to the best degree that we can possible. Keep a little notepad by your bed so that you can write down any of those worries or those things that you have to do the next day, so you're not carrying it and circling it over in your mind. Some additional factors to consider are the bedroom environment. How are you keeping your space? Optimal sleep conditions are keeping it cool and dark. Do you sleep with your animals in the bed, and that might be waking you up? So again, getting a really good sense of that person's sleep environment. Making sure to talk with them about alcohol and caffeine intake, as all of these things and the timing of their consumption can affect sleep processes later on. And then physical exercise is huge. If they're getting physical activity, that we know the research supports that that's going to improve sleep quality and facilitate more restful sleep. So being able to get some physical activity throughout the week will help as well. So here we have a couple of patient examples where we're applying some of the CBTI principles to modify some of their thought patterns and open up new behavioral possibilities. So this is one that was referenced a couple of times today, which I think is quite a common one that we see. If I go to bed early, I'll get better sleep, right? And that's very much driven by this underlying anxiety that I need to stick to a certain bedtime, because that's what you do when you want to have good sleep, right? You do it on the dot. Well, no, you don't. We actually want to keep you up later. We want to let your body tell you when to sleep. So we actually develop a no earlier to bedtime. And there might be psychosocial factors also that are influencing why a person's getting into bed early. So for one person I worked with, his girlfriend was a nurse. So she went to bed really early. She went to bed at 9 o'clock every night. So he would say, you know what, I want to go to sleep at the same time as her. Your circadian rhythm doesn't work that way. Your body's not tired enough to go to bed at 9 p.m. Right? So again, it's really getting to know the patient and what factors are influencing the behaviors that they're presenting with. So we want to help them work on that, changing that thought. I need to allow my body to tell me when it's sleepy. Then I'll get into bed, because sleep cannot be forced. We need to allow sleep to come tap us on the shoulder when it's ready. There might still be some anxiety around doing that, but it could also open the patient up to some curiosity. A lot of the time, they may not be aware of what their sleepy signals are, because they become so disconnected and driven by the insomnia. So we really want to allow them to have those sleepy signals determine when they get into bed. And a lot of times we'll ask the patient, well, how do you know when you're sleepy? And they'll say, well, I just kind of feel tired, and that's when I get into bed. And wrong answer. We want you doing the head bob. You're fighting sleep. Now we've changed their perception around when they're supposed to be getting to the bed. And we've also changed the goal not to force sleep, but to actually fight it, right? To actually fight against that process and use that as a signal when to get into bed. Another patient example, right? So Ambien is a very common medication that we see to treat sleep, and I actually have someone I'm working with right now, she said to me, if I don't take my Ambien, I'll never fall asleep. What if I'm just awake for days on end? There's a lot of anxiety for her around this. And she's told me at the same time, she's like, I hate feeling so dependent on this medication that I've used for so long. So understandably, she's taken Ambien for I think about 7 years now in order to maintain sleep initiation. So we've had to modify that thought a bit and help her realize, while I may, there's a very realistic possibility that she's going to struggle to sleep initially without Ambien, but she will be able to learn strategies to improve her sleep in the long run. So again, there's apprehension, there may be some excitement around that. And one of the things we're working on as she's titrating off of the medicine with her doctor is allowing those sleepy signals to come in, but also getting out of bed when she's unable to sleep. So now we have a patient example of insomnia and medication titration. So this is a patient I worked with a couple of years ago. I'll call him Andy. He's a 26-year-old male requesting to titrate off of Ambien. Always want to assess what the motivation is for titrating off of it. He just said, I really don't like feeling so reliant on this medication. We worked alongside his doctor to make sure he was titrating appropriately. And this is the person I referred to earlier. One of the things he was doing was he was going to bed early. His girlfriend was a nurse. He wanted to go to bed at the same time as her. So a really important focus of our treatment together was revising his pre-bedtime routine and what that looked like. Staying up later. Yes, we wanted him staying up later. So we developed a no earlier bedtime to him of 11:30. Now this meant if 11:30 rolls around and he was still wide awake, you're staying up until you're sleepy. So you may be going to bed later than that, and that's okay. Now you've discovered all of this free time that you didn't have before to do other things. Isn't that cool? Before, he was doing a lot of screen time, right? Watching TV, a really common pre-bedtime practice. We transitioned that to reading, just to avoid some of that screen time. And we allowed his body to dictate when to get to bed. Sometimes that was 11:30. Sometimes that was going to be later. And we also had him adopt to a consistent wake time on the weekends. This is very, very important. So if you're getting up at 7 a.m. for work, you're going to be getting up at 7 a.m. on the weekends. This is not always the most popular fun intervention for people, especially in the beginning, because again, the belief with insomnia is, I got to catch sleep whenever I can. Why the heck am I going to get up earlier on the weekends if I'm still sleepy? Well, that's because this is all going to help with sleep pressure. Sleeping in on the weekends is the reason you're going to have trouble falling asleep on Sunday night. Now you've slept so much, your body's not as tired. So it took him a little time to come around to this, but soon enough he said, man, I'm so productive on the weekends. I'm getting so much done because now I have my whole day. I'm not sleeping in till 10 or 11 o'clock like I was before. So he was able to see the benefits of doing some of these sleep practices. So now I'll share with you a case that I worked with a patient with insomnia and PTSD. His name, I'll refer to him as Paul. He's a 39-year-old combat veteran with PTSD and co-occurring insomnia. At the same time that we were doing CBTI, he was just starting to work with an individual therapist to start to address some of the PTSD-related symptoms. Now, one of the things we saw with Paul, and which we saw with a lot of the veterans, was the alerting signals, right? Now, all of us have alerting signals. The trouble is that with some folks, it's too efficient. When you come back from deployment, or if you're someone who has a lot of anxiety, your alerting signals are going to be too efficient. And one of the ways we can detect this is if the patient says, gee, I wake up when the heater goes on. Everything wakes me up during the night. It's such a pain in the butt. Well, yeah, your alerting signals work really, really well. So you're going to be more of a light sleeper, as we call it. So that's something that we have to be aware of and address. But another thing we had to do was cognitive restructuring to address hypervigilance during the awakenings. When we talked about what he was doing when he woke up throughout the night, he'd be checking the locks on the door. I mean, he was very concerned about people breaking into his home, hurting his family. So he was very hyper vigilant through the house throughout the night. So we had to work on modifying the beliefs that he needed to be awake and monitoring in order to keep his family safe. So we developed a plan, and also thinking about, well, what is this doing for your sleep? I mean, it's really ramping up your anxiety. So we had to develop a plan for what we were going to do during awakenings during the night that made him feel more at ease. So the plan that we came up with that he really learned to enjoy was going to his basement in his house, having a comfortable space where he could cuddle up with a blanket on the couch and then listen to music until he felt sleepy again. And Paul really committed to this and had great results. His willingness to get up during the night, which is not the most fun thing to do, especially in the cold winter, really helped him see good outcomes for addressing those frequent awakenings he was having. So, when should you refer a patient for CBTI? I think there's a few different things to be looking for. If patients are participating in behaviors that interfere with sleep, so if you kind of have your ear open and you're able to hear about anything that might be getting in their way, that would make a good referral. If patients are saying that they really would like to come off of their use of over-the-counter or prescription sleep aids, then CBTI can be a really nice tool for that. If patients are expressing a desire to improve their sleep quality and possibly quantity, remember, quality is always the focus over quantity, but we hope to get them to a point where we can also increase the quantity. Or if the patient's insomnia is exacerbating some sort of comorbid condition that they're presenting with. And here are a couple of resources if you're wondering about how to connect with a CBTI therapist. There's the Society of Behavioral Sleep Medicine, so you can find a directory of different providers who provide CBTI, and also Psychology Today is a really nice resource for finding therapists as well in your area.